All righty. And welcome to our emergency topics in terms of how we look at our patients in a crisis, and particularly as it relates to emergency room access. And today I'm really talking about glycemic control, hyperglycemia, and what's up with that. So a lot of my slides you may have seen before because they really lend themselves very well. I want to remind you that we see a lot of patients that come into the emergency department that are admitted into medical ICUs, coronary units, surgical ICUs, patients who in hospital actually initiate presentation with hyperglycemia, and why this is so incredibly important to us. So the most important statement that I ever make, I just made it last night to my husband who's a diabetic, that glucose in your serum is not glucose in your cell. If the glucose is in the serum and it's in excess, it means that you have cellular hypoglycemia. Now, that's not every cell group, but that's the majority of your cell groups. Serum hyperglycemia equals cellular hypoglycememia. And that's a really important concept to us because we always want to remind ourselves that the number one property really of insulin is to actually transport glucose into the cell. But you have to have some insulin, even if you can't transport it into the cell, you have to have some insulin that actually stores excess glucose as glycogen. So typically patients who have some insulin in crisis will not necessarily go to the breaking down of proteins and fats. They'll go to the breaking down of stored glycogen because they have enough insulin to make glycogen, but not enough insulin or not enough receptor sites to respond to insulin to transport glucose into the cell. So if patients don't have enough insulin to store that serum glucose that's really excessive, store that as glycogen, the cell is starving, the serum glucose is high, and the pancreas is going to release the counter-regulatory hormones. That's more than one, my friends, but the main one being glucagon, the others being growth hormone, cortisol, epinephrine, norepinephrine. All of those are counter-regulatory hormones, but cells that are starving communicate. And if you don't have stored glycogen, that's excess glucose stored as glycogen, you're going to go directly to protease and lipolysis. That's really important to us when we talk about hyperglycemia and we talk about who's really ruling your patients. So we remember that the pancreas releases both insulin and glucagon, and it does that in balance, right? Insulin transports serum glucose into the cell, stores excess glucose as glycogen, and promotes protease and liposynthesis. So if you've got insulin, even if the receptor sites in your cells are low, you're going to store excess glucose as glycogen, and you are going to make proteins and fats. Glucagon is directly opposite, right? It blocks the uptake of glucose into the cell. It promotes the breakdown of stored glucose, that's glycogen, and promotes the breakdown of proteins and fats. So by the way, when we talk about two different crises that patients who have hyperglycemia may encounter, two crises, DKA, glucagon rules and you're protease and lipolytic. DKA, glucagon rules, protease and lipolytic. And in non-DKA crisis, you're going to be profoundly hyperglycemic because you are breaking down stored glycogen. Oh my gosh, so straightforward when we think about this relationship. So again, if you've heard me ever speak about glucomander, glucose, endocrine, you've seen some of these slides before, but it doesn't hurt to see them again, and we're going to look at them in a very particular framework. Okay, so just remember, for glucose to enter your cell, you've got to have active receptor sites, and insulin is needed to unlock the receptors. So when we think about our patients, the patients that we frequently will see, just remember when you join, please mute yourself. You're not automatically muted. Thank you so much, my friends. So you've got to have receptor sites. Loss of receptor sites is typically what we call type 2 diabetes or type 2 diabetics, and lack of insulin is usually the type 1 diabetic. Now, no patients read the rule books before they come to the hospital, and there's a lot of crossover between these two patients groups, okay? So we think about these two patient groups. Type 1, those are insulin deficient. Type 2 tend to be insulin resistant, and then situational because they have sepsis, because they have some pituitary dysfunction related to hyperinflammation, because they have a nidus of inflammation, a fetus. They might have gestational diabetes. So they're not really type 1s or type 2s, they're just hyperglycemic. So just remember, with insulin deficiency, you have receptors, but you can't unlock those receptors. Glucose in the serum, based on the concentration gradient, glucose moves out from the serum, goes to the cell, but cannot enter the cell because there is no insulin to unlock the receptors and to transport that glucose in the cell. So the cells are starving and the blood glucose goes up. Cells are starving. That stimulates the release of glucagon. But because you're insulin deficient, you don't have stored glycogen, you go directly to proteo and lipolysis. The type 2 insulin resistant patient, they have insulin, but they don't have enough receptor sites. So they probably have reduced insulin production, but they have insulin and they don't have enough receptor sites. So glucose goes to the cell, can't get into the cell, goes back to the serum. The cell communicates, I'm starving. Glucagon's released, but now, because you have some insulin, glucagon causes the breakdown of glycogen. So that patient is going to get profoundly and significantly hyperglycemic. That's really traditionally what we talked about, the difference between the type 1 and the type 2 diabetic who are hyperglycemic. Traditionally, this was actually diagnosed in children. It was generally called juvenile diabetes or non-obese diabetes. These were individuals who had failure to thrive. They were unable to thrive because they did not have enough insulin, okay? And in crisis, remember, they go straight to proteolysis and lipolysis. The type 2 diabetic typically is diagnosed in adulthood. That's in the old days. That's when children were thin and some adults were obese. Now all of this is different, but typically we would call adult onset diabetes non-insulin. We also called it obese diabetes. They have insulin, but it's just not enough. And because these individuals, young or old, are bombarding their receptor sites all the time because they have a high circulating glucose because of diet or genetics, they actually have receptor sites that become desensitized. Now, those receptor sites are embedded in the cell. So those sites are desensitized, but they still make glycogen. So in a crisis, they go straight to stored glycogen and they enter a cycle of breaking down the glycogen, yielding a higher glucose. Some glucose gets restored. They break it down again. They break down more. Glucose goes up, goes up, goes up. But glucose in the serum is not glucose in the cell. So in a crisis, it's really important to appreciate and understand the difference between the patient who basically has an insulin deficiency versus an individual who may have insulin, but may have receptor site desensitization. And those are two different types of crises. Now, on a test, on your APP exam, your PCCN, your CCRN, your CEN, we're always going to divide patients into these two populations. Type 1s have DKA in crisis, type 2s have HHS. But in the real world of clinical practice, that just doesn't hold true. So don't get yourself so bound up. Type 1s only have DKA, type 2s can have DKA. That's not true. Type 2s frequently have DKA. Type 1s frequently have HHS. HHS stands for something really important. Hyperglycemia, okay, well, diabetic, you're hyperglycemic. Hyperosmolar, hyperglycemic, hyperosmolar syndrome. So if we just take a look at our plasma glucose and we talk about a patient who presents, who has a history of diabetes, who when we first evaluate them, what we see is that they have metabolic acidosis. So look across the board here. All of these patients, mild, moderate, severe, and HHS, all of these patients have metabolic acidosis. It's significantly worse if the patient has DKA, because not only are they hyperglycemic and most likely hypovolemic, but they are also ketotic, which is donating metabolic acid into the bloodstream. But they all have a relative acidosis: mild, moderate, severe DKA, and HHS. What the big difference is that the person who has stored glucose as glycogen in crisis, their blood glucose is going to be significantly and profoundly higher. Okay, now DKA patients can have a high glucose as well. That's the thing we're going to talk about today. We're going to look at a case that we don't have a lot of information on, a case that came through the ECC and then went up to the medical ICU. I want you to take a look at the case, and I want to look at the patient's labs, because it's very difficult and initially to really know, is that patient in DKA or is that patient in HHS? And does it make a difference? Yes, it does, actually. Okay, so again, if you have mild DKA, you're mildly acidotic. You can see that because the pH 7.25 to 7.3. If you have a moderate DKA, you're going to be a little more acidotic. Your glucose isn't necessarily any higher. It's just that you're more ketotic. The DKA patient has ketosis. That's what we're worried about. And in severe DKA, the glucose isn't necessarily much higher. It's that the patient is profoundly acidotic. Now, historically, we looked at ketones in the urine and ketones in the serum. We saw that there wasn't much when you had hyperglycemia without ketosis, and that it could be mild to severe in the urine and the serum of the person who has severe ketosis. We don't use this anymore to make any kind of diagnosis because it takes time to accumulate and time to clear. So I can have a patient who's no longer in DKA that still has urine ketones and serum ketones. They're just older and they haven't been cleared. So we don't really use that. What we use today is your arterial pH, your sodium bicarb, and or your base deficit. But very importantly is the anion gap. So I just want to remind you, I didn't put anything here about the gap. I'm sorry. I actually could just insert a slide and just write something really quickly, which is what I think I want to do, just so that we're all really clear about what the gap is. So let me insert a slide. The beauty of technology allows us to manipulate things as we speak. The anion gap is a measure of the different ions from our lab analysis. So not what we actually have in our blood, because everything we, analysis, yeah. Oh, whoops, analysis, sorry. Okay, so what we actually have in our blood is going to be different than what we measure in the lab. So we use sodium to represent the positives, and we're going to subtract the measured negatives. Just writing the words out so there won't be any confusion. Okay, so sodium minus, so that's a subtraction. I'll write that word, subtract, chloride plus bicarb. So I add chloride and bicarb together. I add them together and then I subtract them from sodium. Okay, so normally my sodium will be 140. And now I'm going to use a minus. And my chloride will be 100, and I'm going to use a plus here, and my bicarb will be 26. Whoops, sorry, 26. So what that means is 140 minus 126, that difference is 14. Okay, so we're looking at the measured positives and the measured negatives and taking measured positive minus measured negative and looking at the gap. Now that gap does not necessarily exist in vivo unless you have an increase in an unmeasured positive. And that unmeasured positive is hydrogen ion. So when hydrogen ion goes up, it weighs heavily on the positive side, plus hydrogen ion binds to chloride and bicarb. So now the chloride and the bicarb go down. So now what I'm going to do is I'm going to say my measured sodium, 135. My H plus is, I'm just going to put a symbol there and just say it's up So typically we have about 90 nanograms in the blood. So I'm just, whether or not you know that is not going to matter, because you're never going to measure that hydrogen. You're just going to assume it. Okay. So my hydrogen is way up. And the reason I know my hydrogen is way up is because it has to be buffered by my bicarb, and my bicarb has gone down. Okay. So now I've got 135 with my measured sodium minus 100 plus 10. So that means that my gap is now 25. So that means whenever you have a gap greater than 20, it typically means that you have metabolic acidosis. So we're going to use our gap in all of our patients that we are trying to evaluate for DKA. We're always going to use the gap to help us appreciate whether or not that patient has metabolic acidosis. And in the face of hyperglycemia, your patient may have a wide gap when they have ketoacidosis. Okay, so wide gap, really wide gap, typically not just greater than 12, usually greater than 16 or 20. And the bicarb is low and the pH is low. If your pH is low and you have metabolic acidosis, your gap's going to be 20 or greater. In HHS, you may or may not have a gap. You might have a gap in HHS because you have an increased hydrogen, not because of ketosis, but because you're so hyperglycemic, you have almost urinated yourself to death. So a couple of things that are important here. First of all, how high is your glucose? How low is your pH and your bicarb? How wide is your gap? Let me say that again. How high is your glucose? How low is your pH and your bicarb? And how wide is your gap? That's what we're going to look at, because that's going to help us to appreciate and understand your hyperglycemia. Now, we always appreciate that you may not be diabetic, but you're getting neosynephrine, you're getting epinephrine, you might be getting corticosteroids. You have issues that actually promote profound breakdown of proteins and fats. That's what epi does, very significantly related to epi. It's called epinephrine-induced ketosis. Also happens with norepinephrine. Very important to appreciate that we can increase the breakdown, the liver breakdown of glycogen. That happens with epinephrine. It also happens if you're giving the patient glucagon, but you don't really care because you want that to be happening when you're giving glucagon, but you're not thinking about it when you're giving epinephrine, that you're promoting gluconeogenesis, the breakdown, that's the breakdown of proteins and fats yielding ketosis, the breakdown of stored glycogen. You're promoting insulin resistance with epinephrine, and epinephrine inhibits insulin secretion. So by the way, your patient's on epinephrine, he's going to be hyperglycemic. Does he need insulin? You bet. In fact, the real truth of the matter is anybody with the blood glucose of greater than 180 times 2, they need to be on insulin. We under-resuscitate with insulin in almost everyone's hospitals, but certainly here at Grady, so profoundly under-resuscitate with insulin, and that hyperglycemia is really dangerous. Now, in general, people under-resuscitate with insulin because they're fearful of hypoglycemia, which makes perfect sense. But I just want to make sure that we appreciate that not all your cells require insulin for the uptake of glucose. Cerebral cells will always uptake that excess of glucose. Myocardial cells will uptake that glucose without insulin. That means that if you came in for a stroke and you're under my care and you have a blood glucose of 198 and 210, 2 hours apart, you have extended your infarct, your cerebral infarct, your myocardial infarct. If you're in my care in the surgical, the CVICU, and you are post-bypass, and you had a blood sugar in the OR of 190 and your first blood sugar in the ICU is 200, and I don't put you on insulin, I have extended your myocardial dysfunction and put you at risk for failure to wound heal and infection. I'm in charge of that. I, as the bedside nurse, I, as the APP, I'm in charge of that. I need to get my patient on insulin and do it quickly, because we know that if you have sepsis and you have hyperglycemia, and I'm not talking about 300 and 400, If you have hyperglycemia and sepsis, you have a 7-fold increase in mortality. And you know, when we really understood this was during COVID-19 and looking at the 7 to 10-fold increase in mortality in COVID-19 positive patients who were allowed to be hyperglycemic. And we all over the world loosened up our control on glucose in COVID-19 because we didn't want individuals to have to go in and out of the room too frequently, having to put on PPE and exposing themselves going in and out of the room of patients with COVID-19, but that profoundly affected mortality. What's up with hyperglycemia? It's life-threatening. It increases mortality. And of course, it's not quite as worrisome in the moment as hypoglycemia, which is why many of us have chosen to use electronic glycemic management tools to help us protect patients from hypoglycemia. Okay, so indications for an insulin drip, by the way, if you got a gap. If you're hyperglycemic, but you don't have ketosis, if you are hyperglycemic and you do have ketosis, if you got a gap, you need to go on insulin. We want to remember that we're going to put patients on insulin because they're critically ill. Because the more they decompensate and the more acidotic they become, the worse they get. Remember that when your pH is less than 7.25, you actually generate now a picture of vasoplegia, and you're not really responding to catecholamines. You're not responding to vasopressors. Always step back when you're titrating up on vasopressors to evaluate whether or not that patient's hyperglycemic. There's a lot of metabolic acidosis that in a critical illness state you can't really control, but you can control ketosis. So that's something to really be thinking about when your patients have a refractory hypotension and they are hyperglycemic. Just because your doctor or your providers didn't order it doesn't mean your patient doesn't need it. You need to get it, and you need to get it right away, okay? We certainly know that patients postoperatively who have hyperglycemia are going to have a significant reduction in survival and a significant increase in morbidity and length of stay on the ventilator in the ICU if we don't get them under control. Neuro tends to be the best unit in the world in everyone's hospital. If you've got a neuro ICU, they do not allow hyperglycemia. They do not allow hyperglycemia. Reducing hyperglycemia in stroke and bleed patients significantly improves outcomes. So we want to think about that for all of our patients, okay? Now, if you're in DKA, we're going to know that by a gap. If you are in a non-ketotic hyperglycemic state, critical hyperglycemia, like HHS, hyperglycemic hyperosmolar non-ketotic syndrome is what used to be called HHNK. We don't call it that anymore because sometimes these patients do have ketosis. But what you want to appreciate is that your kidney only has capability to reabsorb so much glucose. So most of the glucose is now going out, is being filtered and being removed in the urine. And what always follows glucose, because it's hyperosmolar, is water. The higher your glucose, the more dehydrated you're going to be. Okay, you're going to waste salt. You're going to waste all sorts of ions and electrolytes when you are urinating from hyperglycemia. So that is a really critical and profoundly important aspect for you to appreciate. So this is a patient who came into the emergency department this morning. And I'm going to show you what his initial glucose was. He is profoundly, severely insulin resistant. I'm going to tell you that right now. He comes in here, he's at 758. His first blood glucose on point of care evaluation is greater than 600. The nurse tells me she was monitoring the glucose all day, but she just didn't put the glucose into her glucometer. That's okay. We're not here to talk about that. But the next measured glucose patient was still above 600. Now he is now on 9 units of insulin. He's still above 600. Then the nurse looks at the lab value. She says, oh, the lab says 784. 4 minutes later, she puts in 784, okay, and increases the insulin and then transports the patient upstairs to the MICU where they measure the next blood glucose greater than 600. Okay, so Shri, I'm not going to try to put you on the spot, or Sush, either one. Not trying to put you on the spot, But what do you know you never do when you're on the glucometer? What do you never do?
So we are never.
What you're looking at here, just what you're looking at.
So we are supposed to put it in the point of care glucose that we do with the glucometer at the bedside, not the one from the serum.
Okay, excellent. Thank you, Sush. Yay, excellent. Never put in lab data. And if you're not using electronic glycemic management, I know I've got 1 or 2 folks on here who are not from Grady, and that's totally fantastic. What you want to remember is whatever comes from the lab is old data. It might be 30 minutes old. It might be 4 hours old. It's old data. And because we use an electronic glycemic management system, you never, ever put in anything except the patient's point of care glucose. Now, what Glucomander does is we started on insulin. We started on insulin at 9 units. And number 1, 9 units, number 2, 9 units, number 3 would have stayed at 9 unit, or actually, I'm sorry, started at 5.4 units. We'll look at that in a second. 5.4 units would have stayed at 5.4 and then titrated upwards, but it doubled the patient's insulin dose when we put in 784. Glucomander is not AI, doesn't say, hey, you can't give me a 784. It accepted the 784, but that's old data. And then right here, right after that, the patient got transferred to the MICU. So I was really grateful. Someone called me. I came and looked at the patient, called the MICU. My fabulous friend and partner, Norma Poindexter, Dr. Poindexter. I called her. I said, listen, I'm really worried. Can you adjust and can you measure the blood glucose? And let's get this under control before the patient really drops his blood glucose, because we doubled his insulin based on that. So excellent, Sush, really good. Okay, so now I just want to remind you, when we talk about, so here's our patient who's very hyperglycemic. We haven't looked at anything else. Patient is ordered, that patient that we just looked at is ordered on a DKA protocol. And remember, it's very common for our docs to say, hey, it's a type 1 diabetic, hyperglycemic, got a gap, they have DKA, I'm going to order the DKA protocol. Here at Grady, our DKA protocol, very important. The DKA protocol is a Grady protocol. The only thing that the Glucomander does is it actually assists with the telling you how to adjust your insulin and telling you how much D50 to give if your patient's glucose drops below 70. That's all. Doesn't tell you about giving fluids, doesn't tell you about potassium replacement, doesn't tell you about giving patients glucose to replenish their glucose when you're giving insulin. So we have a protocol, and everybody's got a protocol for glycemic management, and you need to be rigorous with your protocol. With DKA, no matter where you work, no matter where you are in the world, the focus with DKA is the absence of ketosis. That is number 1. We are titrating insulin to obliterate protease and lipolysis, which may mean that you get your patient's glucose down, but if they're still ketotic, you're going to make them have a higher glucose so you can continue to give insulin. So in the Grady protocol, which I think is probably very similar to other people's protocol, should be, that when a DKA patient's glucose drops below 250, you add D5-LR at 150 an hour. If their blood glucose level drops below 150, you add D10 at 150 an hour, which means for any DKA patient under your care, you need a bag of D5-LR and a bag of D10, and you're going to go back and forth between those once your patient's glucose comes down, because you're going to give them glucose to balance the insulin to stop the ketosis. Sounds like oh, I'll have to do that for another time. You know, I knew an old lady who swallowed a spider, who wiggled and jiggled and giggled inside her. She swallowed the spider to catch the fly, right? Or whatever. I don't know why she swallowed a fly. So that's the same thing here. Your patient has ketosis. You're going to give glucose along with insulin to stop ketosis. And once that's obliterated, you should come out of the DKA protocol, because it requires a lot of effort on the nurse's behalf, trying to keep the glucose up while trying to obliterate the ketone. With HHS, it's a little bit more straightforward. First and foremost, with HHS, if you give volume, and volume, you may be able to get your patients glucose down. Then you add in insulin, and the insulin is about controlling the glucose. So this is crisis. This is not just standard hyperglycemia. This is crisis. And we always will say DKA is common for type 1, HHS more common in type 2, and it's a crisis situation. So again, I'm going to go back and look at this patient. Okay, so here's my patient. His glucose by point of care is greater than 600. By lab is 784. He has a gap of 26. So naturally, the perspective is that he is in DKA. Okay, we'll look at some more of his labs in a second. But because he's got a wide gap, you already know he's acidotic. He's acidotic. Okay, his pH less than 7.3, bar carb less than 15, base is in deficit, gap is 26. Okay, probably has positive serum and urine ketones. We're not looking at those. That's really old fashioned. We don't do it much anymore. We don't really care. Okay, so very, very important for you to think about this and that he has a precipitating factor. Okay, now here come his labs. Okay, so here's his first set of labs. Okay, 925. Okay, so this is a venous blood gas, but remember, in a venous blood gas, your pH is normally around 7.32 to 7.42. So your patient is profoundly acidotic. Check one for DKA. His PCO2, normal PCO2 is typically 35, normal PCO2 is typically 40 to 50. His is 27. He's very hypermetabolic. He's consuming a lot of oxygen. And look at his base deficit. His base deficit is negative 27, normal base deficit negative 2. So his pH 6.9, he's got a base deficit. And then I'm going to go down to his chemistry. Okay, well, his potassium is almost 6. So, okay, I want to remind myself that in the presence of acidosis, not just ketoacidosis, metabolic acidosis, hydrogen ion moves into the cell is protecting you from acidosis, and the cell is releasing potassium. So I've got a high serum potassium. The kidney is if you're making urine, is wasting metabolic acid hydrogen and retaining potassium. So I'm getting potassium from two directions, from the cell releasing potassium into the serum and from the kidney, which is releasing metabolic acid and must reabsorb potassium when it releases the metabolic acid. So my patient gets hyperkalemic. Okay, good. Everybody good so far? Then I'm looking at the total serum CO2, which is bicarb, normal bicarb 22 to 28. And your bicarb here, this is serum CO2 is bicarb, is 5. Your patient's acidotic and he's got a wide anion gap. Now your glucose, this is his first lab, is quite elevated, 784. Okay, so yet again, if we look over here, Sush, Shri, Laquanita, I'm not sure who the Zoom user is, but if you look over here, you see that we are actually 5 hours into the patient's stay. And what happened is the nurse input the glucose from that morning, which was at 9:25, but I'm 5 hours into the stay. So it's all good. This isn't meant to make anybody feel bad. It's just really important to think about how we utilize our tools and what we kind of expect. So at this point, the patient, of course, has been on insulin for a while now, and patient is on a DKA protocol, By the way, the DKA protocol is really gentle. It actually starts with a much lower factor, which means your insulin adjustment in the beginning is really, really, really low. And our focus here will be to protect the patient from hypoglycemia, to give fluid, and to consider electrolyte replacement. Okay, so now we take a look at our patient. We take a look at our patient again at 12:01, and look what happened here. Serum sodium 129, and now it's 136. Okay, serum potassium 5.8, and now it's 5.5. Chloride is up a little, total serum CO2 is up, gap is down just a little, and glucose is down a little bit. Okay, not profoundly down, a little bit down. And then I just want to look at my patient's creatinine, okay, and my patient's urea. Okay. So I'm going to tell you two things. The first thing is, I'm really okay for this patient to be on a DKA protocol because I really don't know whether he has DKA. He needs a beta hydroxybutyric acid evaluation. I'm sure that somebody ordered one. You can see his lactic acid is elevated, but lactic acid elevates when you're hypoperfused and when you're hyperglycemic. Lactic acid is not the magic bullet that we would like it to be. His lactic acid is elevated. I'm going to tell you, looking at the information that I have right here, looking at this, I would not be able to tell the difference between DKA and HHS. And I don't care, actually. I don't care. I know when I'm looking at the BUN, I know the patient's dehydrated. Can he be dehydrated in DKA? Yes. Will he be dehydrated in HHS? Absolutely, yes. So what am I going to give him? Normal saline. Okay. Well, when I looked at this in the beginning, I might have said, oh, his sodium is 129. Okay, guys, time for a little math. Probably need to put in another little slide. Sorry about that. Didn't even think about it when I was looking at this and when I was putting it together, and I was doing it really fast because I had a trauma surgical talk for the hour before this. And then I was seeing this patient and other patients prior to that. I just didn't have as much time, but I'm going to do something very important here. For every 100 milligrams of glucose greater than 100. Correct sodium. Now, we're not really correcting the sodium. What we're doing is correcting for your dehydration, because sodium tells me about dehydration. So I'm going to correct the sodium. For every 100 milligrams of glucose greater than 100, I'm going to add 3 MEQs. Oh my gosh. Okay, so our patient's sodium was 129. His glucose was 783. So I'm going to round that up to 800. That's 7 100ths greater than normal. So now I'm going to say 7 times 3 equals 21. I'm going to add that 21 to my patient's measured sodium, 129. And that makes my corrected sodium 150. Okay, now why do I correct that sodium? I don't correct that sodium so I can say, oh, doctor, look, your corrected sodium is this, that your low sodium isn't real. No, that low sodium is real. Your patient has low sodium. But for the amount of glucose that the patient is passing through the kidney and into their toilet or their Foley, that's how much sodium you're wasting. And so you're going to use this corrected sodium when you do a calculation of the patient's osmolarity. And that is going to tell you how dehydrated your patient is. Now, did I really need to do that? Me, myself? No way. I don't care that your sodium is 129. I can see that you're profoundly hyperglycemic. You're so hyperglycemic. And I'm going to look at your BUN. Oh my God, you are profoundly dehydrated. Honestly, I don't care if you're on a DKA or a non-DKA protocol. I don't care if my doc says DKA, HHS. At this point, all I know is my patient needs insulin, my patient needs volume, and he is acidotic. So I'm going to be really careful because as his acidosis resolves, he will probably need potassium supplementation. Why is that? Because once the acidosis resolves, potassium goes back into the cell. Once the acidosis resolves, my kidney stops wasting hydrogen and will start wasting potassium. So that potassium, which down in the ECC was 5.8, by 5 hours from now, that potassium is going to be 1.2 if we don't replace it, because we're focused on, for this patient, we're focused on controlling the glucose. If we think he has ketosis, controlling the ketosis and giving volume. And if he actually has hyperlactatemia and metabolic acidosis from hypoperfusion, as we give him volume, we will resuscitate his acidosis. Oh my God, what a fantastic thing. How much fabulous control do we have over this? So lots of things make DKA diagnosis difficult. Things that actually release bicarb. So the patient has the flu, he's been vomiting. So he might have a mixed acid base balance. He might have actually mixed metabolic acidosis and metabolic alkalosis. So we have to look farther into that. We do something called a delta gap. We're not going to talk about that here today, but I'm happy another time to do it. If they are receiving certain types of insulin therapy, SGLT2 inhibitor, that's one of the newer forms of insulin therapy, or if they are pregnant, they may have normal to mildly elevated glucose, but they still have ketosis. These guys get missed a lot because they have a normal glucose, but they have profound acidosis. That requires, of course, that you do a beta hydroxybutyric acid evaluation. And in patients who have significant osmotic diuresis, well, anybody who is hyperglycemic will have osmotic diuresis. I like to remind you that the commonality of the word diabetes, so don't get hepped up here, don't get upset, okay? So you are hyperglycemic with DKA, you are hyperglycemic with HHS, you are not hyperglycemic, but you have diabetes insipidus. If you have that word diabetes, it means you have a lot of diuresis, and it's generally osmotic diuresis. So really, really important to remember. And it makes DKA diagnosis difficult. I feel that this patient has a little bit of difficulty making that diagnosis. Now, once he got upstairs, they took him off the DKA protocol and put him on non-DKA. I don't think it really matters very much. I don't think it's a big problem. Okay, great. It's going to be much easier for the nursing staff because they're not going to worry about D5LR and D10. However, if the patient actually is in DKA, he's going to plummet his blood sugar at some point. Not right now, because right now he's at 514, right? He's been on insulin since 7 this morning and he's at 514. Now, the process of using glycemic management is, and I just loved that Sush had the right answer. That was so fabulous, is that what happens with glycemic management, our tool, is if your point of care is greater than 600, you have to have 3 measures in a row greater than 600 before you will be advised to increase the insulin, because your patient's glucose is coming down slowly and surely. You never want to drop glucose, right? Really, you don't want it to drop more than 50 an hour. Never more than 100 an hour. And what did happen to that patient is that he did get dropped more than 100. He got dropped more than 100 because we put in the laboratory value, we doubled his insulin, and thank God somebody called me and said, can you come look at this and tell us what you think? I went and I looked, I said, where's the patient? I want to go back in. We need to make an adjustment. We've doubled the insulin. He's really at risk. He had already left the unit and was up in the MICU. So I called Norma right away. I said, Norma, I'm really worried about the patient. We need to go measure the patient's glucose. So she did. And thank God the patient's glucose was still above 600, but then 30 minutes later, it was 510. And we don't want to be dropping glucose that quickly because that promotes osmolar shift. So there's really a purpose in the way in which we manage hyperglycemia. It's always important to remember with hyperglycemia, you're going to have osmotic diuresis. Always, you're going to have osmotic diuresis because the kidney wastes that glucose and water is always going to follow. What also is going to follow that is sodium. And if your patient is acidotic, hydrogen ion. And what you're going to preserve, what you're going to keep inside is your potassium until the metabolic acidosis gets treated. And as soon as that's treated, and it's treated by giving volume and giving insulin, once the acidosis disappears, potassium moves back into the cell and moves back to the urine. And all of a sudden, your potassium that was 5 is now 1. And the number 1 cause of death, of course, with DKA, number 1 cause of death with DKA, sorry about that. Number 1 cause of death with DKA, of course, is a hypokalemic cardiac arrest. So lots of other things we could say, but really what we want to consider and what we want to think about with DKA and HHS is always just to remind ourselves that we want to talk about insulin. We want to talk about monitoring. We want to talk about making sure that you're taking your insulin, even if you're not eating, if you have DKA. So again, we just remind ourselves about DKA can really present very rapidly. Typically, it presents quickly, usually in the space of 4 to 12 hours. Almost always less than 24 hours. So I measured my blood glucose 30 hours ago. Things looked okay. I got a little infection. I had some food poisoning. I'm not eating. And all of a sudden, I am now ketotic. Okay. HHS takes much more time. So I didn't really look at this patient's history. Maybe the physicians talked with the family. Patient was getting worse and worse and worse over the last 4 or 5 days. He was getting more and more changes in his mental status. He was basically comatose when I got called about him. He was not cognitive, but they had polyuria. So daddy was going to the bathroom a lot. We had to put a diaper on him. He can't get out of bed. We're changing his diaper a lot, or he complained about going to the bathroom. He drank 4 quarts of water because he's polydipsic, but that happens over several days. So DKA is really fast. HHS is slow, but both of them present with dehydration. So that's really important, because if I have DKA, I'm ketotic and hypoperfused and hypovolemic. With HHS, I may not be ketotic, but I'm going to have increased lactic acidosis. I'm going to be acidotic because I'm hypoperfused, because I generally, for HHS, I present in hypovolemic shock. So what's first and foremost? Fluid, insulin, fluid, insulin, fluid, insulin. So again, textbook only, passing a test only, DKA, glucose above 250, but usually less than 600, pH down, bicarbs down, ketones positive, may have ketones in the serum, usually has a wide gap. And this should be greater than 20. I'm sorry, that's my fault, greater than 20. HHS, glucose greater than 600, pH typically greater than 7.3, bicarb greater than 15. Okay. Serum is very, very concentrated, particularly when I correct for sodium and plug that corrected sodium into the calculation. And the patient oftentimes is comatose. Okay, so we go back, and I'm just going to go back to our patient's labs, and you're going to appreciate again why I say, looking at what we have here, which is the labs that were done basically in the ED, one at 9 in the morning, and then one right before the patient left the ED. My patient is profoundly acidotic, not hypoxic, profoundly acidotic, hyperventilating with a severe base deficit. He has a high potassium, he has a very wide gap, he has a low bicarb, he's hyperglycemic, he has a high BUN and a high creatinine. And his osm, calculated osm, is 308, which is just a little bit high. But if I factored in the corrected sodium, his osm would be around 325. That's really serious. It's a really serious dehydration. So I am again going to tell you, I wouldn't be that worried at this point about whether he's on a DKA protocol or a non-DKA protocol. Really, really important to just appreciate, I've got to give this patient a lot of volume. I've got to get him on insulin, and then I'm going to monitor him. So his gap is now 26. And he's gotten some volume, probably not enough. Don't have any more recent labs. I'm sure they're getting some labs shortly. But what I would tell you is, don't sweat the small stuff. The difference between the DKA and the non-DKA protocol, and La Quinita, I really need you to hear me. This is so important. The difference between the DKA and the non-DKA is the DKA protocol uses a lower multiplier to start with. It's just the initial. So the first adjustment of insulin is less aggressive than in the DKA protocol, but a non-DKA, but we can always order the lower multiplier. We can always order a multiplier of 0.01, which means that the very first insulin adjustment is going to be slower. The DKA protocol overall, because the multiplier is lower to start with, it's a slower adjustment. It's going to take more time for the patient's glucose to come down. And that's because when you give a patient who doesn't have insulin, you give them insulin, you can plummet their blood glucose. That's really important. They don't have insulin. patients who are type 2s are insulin resistant. So I can give them insulin and they typically don't drop their glucose quite as aggressively because what I'm doing is trying to overcome their insulin resistance. And I have to give a lot of insulin to overcome their insulin resistance. So what I'm going to tell you is that based on how this patient is responding, I think he's insulin resistant based on how he's responded to the insulin. Because right now he's on 16 units of insulin. 16 units of insulin. He's insulin resistant. And when you're caring for patients where you're going up and up and up and up on the insulin and they're really not coming down, you have to consider three things. The most important one, first thing you're going to do is the IV working? That's the first thing. Okay, number one. Number two, we're here at Grady. So number two, is this patient eating even though he's not supposed to? Did he have a candy bar? Did his family bring him something to eat? Number one, is the IV working? Number two, is the patient eating? So you got to go in that room and just say, listen, no problem, but I need to know, have you been eating? Because I'm having trouble with your insulin. Number three, the insulin may be ineffective. It could be from an older batch. You can always call the pharmacy and say, I need another bag of insulin. But number four is that the patient is insulin resistant. So what we're going to do is we're going to continuously adjust insulin upwards until we break the resistance. And then that insulin is going to be titrated back down. It is a magnificent thing. You cannot believe the change in our method when we really understand the purpose of glycemic management, insulin administration, and patient protection. So if I'm going to see you next week, I'm going to follow up on this patient. I'm going to let you know how things go. I anticipate probably by around 8 o'clock, we'll have broken through his insulin resistance and will be right with his world. I did, Norma texted me while I was on the phone with you, and I kind of tried to answer her and just said, make sure they're giving lots of volume. I think they are. I think that they're being very aware. But here's the thing. They said, she said the docs changed him to a non-DKA protocol because they want to adjust the insulin less aggressively. Hey, flash, the DKA protocol is the less aggressive formula for adjusting insulin. Because remember, if you have DKA, you don't have insulin. If we give you insulin, you'll plummet your blood sugar. That's why you get D5LR. That's why you get D10 in the DKA protocol. In the non-DKA protocol, we're overcoming your insulin resistance. But I'm really happy that they put him in the non-DKA because quite honestly, I think he's insulin resistant. Right now, as I said, on 16 units of insulin. So stay tuned. We'll find out how he does. I hope that this was enriching for you. As always, whoops. Oh, and that is, I'm sorry, let me just turn that off for a second. That's the alarm that's telling me it's time for them to adjust their glucomander. So let me just be sure that I've turned off my glucomander, come out of my glucomander, come out of my screen, and come back. Actually, we can take a quick look at our guy if we like. I'm just going to look at his numbers. I'm not going to share them with you because it's I can't anonymize it in real time, and I would need for it to be anonymous. But I'm going to take a quick look at him. Okay, he's at 416. So still coming down kind of quickly but beautiful. So in 1 hour, he came down 80. So remember, we never want to go above 100. So he's trending down nicely. They're not going to measure another gap on him for a while. He's just going to stay where he is right now. And when we put him on, I gave them his custom multiplier, which was 0.0397, but his multiplier now has adjusted downwards to 0.02. So when he went upstairs, he went from 9.1 of insulin to 16.4. And now we've broken his insulin resistance. We're coming down on his insulin. It's now 7.1. Another patient saved by the glory of the glucomander and the Grady. Woohoo! Glory of glucomander and Grady. Insulin control extraordinary. Thank you all so much for everything you do every single day. Thank you for joining me here on Emergency Excerpts today. I just want to remind everybody, next week I will be lecturing at this time at NTI in Houston. And the following week, I am on vacation. So next week, I will send out for all of you, plus if you're not a Grady person and you're interested, just email me your email and say you want to be notified about next week's virtual topics. They will probably be an hour later than usual. I'm so sorry, but that's the best that I can do because I'm lecturing all day until the end of the day, and then I can do my virtual topics. I don't want to miss virtual topics because I have some people that follow me and I'm really grateful for that. And I want to be sure that we're together, expanding our knowledge and practice. So just keep your eyes wide. Next week's virtual topics will be late. The following week, I'm on vacation, but I'm going to do my virtual topics on time, Eastern Standard Time. I'm happy to discuss things that you might be interested in if they're within my framework. If they're not within my framework, I can try to find somebody who can discuss them for you. And I'm always happy to review a case or have some other types of discussion. So with that, I'm going to end my lecture. I'm going to stop recording